Going for a 20 minutes break, and I would like to thank before the break Senior Executive Dan Palino, Sean Hogan, and Michael Bile from IBM for the generous support of this event. Thank you very much, and we'll be back at 3:20. Thanks a lot. This is going to be a very important panel. I'm looking for David Klein. Okay, you're here. Okay. So just give me a few minutes, and we'll get everybody coming on stage. There's something which is very important. I would like to remind all of you. Okay, we'll wait for the photo op. Yeah. Okay. I hope we'll get the pictures later. Yeah. We'll put them on the website. Yeah. Okay. Please grab your seats, and I'll make sure. Don't switch your signs. Okay. So. Okay. As you probably heard today, and all of you, in one way or another, come from scientific background, remember science progresses by measurement. And you cannot imagine medicine today without EKG, without MRI, or even without a microscope. So the more measurements we have, the better job we can do as scientists. So at one level of measurement, we are going to the cell level, at the cell components. Another level of measurement that you heard about today a lot is the patient movement, patient life, monitoring patient throughout the lifetime. So these are very important things that we need to recognize. The other thing which is interesting when you look at the interface between medicine and IT, it's almost like the difference between physics and chemistry. And I cannot resist sharing you my own experience as a university professor. I went once to a seminar in the University of Rochester, laser lab. And there was a discussion there of some plasma phenomena, some high energy issue. And one of the professors, who is a chemist, presented the explanation to the phenomena. And people raised and asked questions, and he said, well, I'm sorry, I can't explain it. I don't know the answer. And a few minutes later, a physicist came in and provided similar explanation, and somebody from the audience raised their hand and said, can you explain it? And he says, nobody knows the answer. So there's a difference, okay? So how modest you are is very important. But the key thing is, when we go to the next panel, is the following issue. One, as you heard today repeatedly, one of the most challenging economic, political, and philosophical issues is the way to which society and individuals are going to pay for healthcare. We're all asking ourselves, is the fee-for-service horse race almost over? Will pay for outcome really take over? Will accountable care organization be the next magic bullet? And who is going to pay for all the new technologies which are coming almost on a daily basis? We see new development in pharma, in biotech, etc., etc. We always ask ourselves, what's the future of bundled payment? What will be the impact on cost reduction and patient satisfaction? The big issue is very simple and frightening. We're now approaching 18 to almost 20% of the gross domestic product going for healthcare. It's becoming crystal clear to politicians as well almost to everyone that the public will not be able to afford any much growth beyond it. We cannot grow over 20% of the gross domestic product without collapsing our economy. So the question is, what do we see happening around us? And from my own research, I call it the 5 C's that we see right now in healthcare, and the panel will talk about the economic implication of it. One is commodization. Medicine becomes a commodity. If you look now at lab services, rehab, medical imaging, or urgent care, the patient doesn't really care which physician is there. The way you don't care which pilot is flying your plane from here to London. You just don't care. The average don't care, and they don't know. It's become a commodity. The second C is consumerism. Consumers now have a lot more say than ever in the past. They have high deductibles, and they want to get a good use for the dollars. Okay? Not everything is covered as it used to be in the best of program. In addition, with patient surveys, with price gaining, with Twitter, with their website feedback, patients feel they have a lot more control as consumer. The third factor is competition. Businesses are competing at a much greater rate, and the question is it going to affect the way they attract patients, keep patients, the way they attract physicians, providers, and so on. The fourth C is consolidation. Everybody is buying everybody these days. There's a theory, but nobody really knows for sure. There's no scientific base for it, that bigger is better in healthcare. Okay, and people are growing. And the idea is that probably in 10, 15 years, some expect we'll have maybe 10, 15 healthcare chain providers all throughout the United States. Like we have similar number of supermarket chains or gas station chains or pharmaceutical chain. Okay? But the M&A trend is not over, and we see a lot more of it. And the final one is the contraction. The primary care solo practice has disappeared. Rural hospitals are disappearing. Freestanding medical imaging practices are disappearing. And you see a lot more contraction in the industry as time goes by. So all those things has tremendous impact on the way we are going to monetize, pay, and care for healthcare. So we assembled this panel with some leading experts on financial disruption in healthcare. And we would like the panel moderated by David Klein. David Klein is an expert in the field. Currently, he serves as a special advisor to our university CEO. And prior to that, David has run a very successful career in building the Lifeline healthcare company in upstate New York. It's a family of companies that provide healthcare coverage and care services to about 1.7 million lives. So he has a lot of experience on the financial side as well. So please give David and the panelists a big hand. Thank you very much for joining us.
Avi, thank you. Thank you. You know, I'm going to be disruptive right from the very beginning here. I'm going to stand up and let my real experts talk, and I'm just going to sort of play traffic cop. So hopefully that's okay. And what I thought we'd do is try to make this sort of conversational, and we're going to start, you know, with the panelists. I'm going to ask them a really easy question to start with, like what's their name and why are they here? So we're going to start with you, Ralph.
Thank you. I'm Ralph Muller. I'm the CEO of University of Pennsylvania Health System, where Ray and I work together, so he invited me here. I'm glad to be here today. We're a big place, one of the big academic centers in the country. We serve about 3 million patients a year and cover a big geography, like many of the, I still think most healthcare is local, to paraphrase Speaker O'Neill. So I think that's still true. And I'm glad to be in. And I think the introduction, there were a lot of provocative points there, but I'm going to take those on in a little while.
So we'll come back to that in a second. Walter, please.
Hi, I'm Walter Koroshetz. I'm the acting director of the National Institute of Neurological Disorders and Stroke at NIH. And we're trying to solve the problem of the aging population by getting better treatments, preventing brain disease in people who age.
Thank you. Brian?
Brian Flanagan. I'm a partner with Deloitte Consulting based in Chicago. I lead our go-to-market service offerings for life sciences and healthcare. I also lead our value-based care practice, and prior to that, led our M&A practice in the U.S.
Emily?
I'm Emily Drabant-Conley. I lead business development at 23andMe, and we're a company with a twofold mission. The first is empowering people by giving them direct access to their genetic information and the tools to understand it. And notably, we received the first ever FDA approval for a direct-to-consumer genetic test earlier this year. And then the second part of the mission of the company is building a massive genetic genotype-phenotype database for research. So we have almost 1 million people in that database now. And we've recently launched some of our own internal efforts to mine that data to better understand the genetic basis of disease.
And Bob, please.
I'm Bob Carey. I'm a managing director at Allen & Company with a focus on assisting healthcare companies, mostly technology companies, and mostly IT companies.
So let me just sort of give you a warm-up question here beyond the self-introductions. And you know, we've heard a lot this morning and early this afternoon about, you know, big picture. We've heard a lot about some, you know, very neat innovations that are taking place. Okay. What's the big takeaway that you have, you know, right now? And I'll go in reverse order, Ralph. Okay. So we'll start with Bob, please.
Well, I just got here, so I don't know what the people are saying. I know Seth because we've through Allen & Company have helped honor. And I do have to say, I mean, amidst the disruption, that I think the baseline for me, any time I talk about healthcare, is a memory of what it was like when my first child was born in 1978. We had what is an archaic product at the time called what do they call it for emergencies, for a high-cost healthcare. I paid cash for my son. I paid cash for my daughter, who was born 2 years later. It wasn't a financial catastrophe to have a baby and be uninsured. Today, it's a financial catastrophe, even for normal vaginal delivery, let alone a more difficult delivery. So I say it because for a significant number of people living in the United States of America, they simply cannot afford even sort of reasonably evaluated health care. They simply can't. In 1978, most people in Nebraska who were in the workforce had health insurance as a part of their employment, and they had post-employment health care when they left. That no longer exists. So I begin this thing saying, before we talk about the disruption, the cost of health care is still disrupting an awful lot of individuals in America, even with the Affordable Health Care Act, which is exceptionally difficult to figure out. But at least in my view, it's better than what we had before. So I start off any conversation about technology and disruption suggesting, though we get an awful lot out of it, the current cost of health care disrupts an awful lot of individuals that simply can't afford to pay their bills.
Emily?
Yeah, I think one of the takeaways for me today is that the consumer is the loophole. If you think about innovation in other sectors that have innovated well, like smartphones, for instance, that innovation has been demanded by consumers that want the technology. We all have smartphones. We're willing to pay for them. And the innovation has been incredibly fast. And I feel like healthcare is one of the sectors that's lagging, where consumers have not been the central focus of that. There are all these other players, payers, the system. But when we start thinking about empowering the consumer and having them kind of at the center of that equation, I feel like then we're really well poised for innovation and for disruption. And that's what we're thinking about a lot as a company. How do you engage the consumer patient and empower them so they can take better care of their health and utilize all of these technologies that we're growing?
So cost in retail. Brian?
So there was interesting discussion this morning about how siloed our industry is and how big of a problem that is. And the fee-for-service, volume-driven model has really reinforced it because we have a zero-sum game across our industry constituents capitalizing on marginal price, marginal cost. Well, what we're moving to and what the industry needs to move to is, in this value-driven environment, is more horizontal integrated relationships across the ecosystem. And I think technology is going to play a critical enablement role, but we have to first start with net new business relationships. As we look across the ecosystem, there are a lot of parties who don't know one another. And this is going to take a lot of time to develop first these net new business relationships and then net new economic models and economic relationships across our industry that then can be enabled by technology.
So a different ecosystem. Walt?
Well, I'm a big believer that the revolutions are really generated by new tools. And the problem that we're facing, I think, as the population ages, is basically one of brain health. So as people age, I think the paramount concern is when brain function starts to deteriorate, and we need to prevent that. Now, it turns out in my business, which is trying to help develop better therapies, the major roadblock is that we don't have really good sensitive measures of brain function. So if you want to develop a therapy and you have to wait 3 or 4 years to see if it works, that's a deal breaker. But the brain is, the human activity is a great reporter of how the brain is working. So the way I'm moving my hand, that's a part of my neurology. And if that changes, something's changing. And so the sensor technology I think we heard about today to give you continuous monitoring of human activity is really reflecting, has the chance to reflect what is going on in the brain. And this, I think, is a potential game breaker, a game changer for developing new therapies.
So different barometers.
Right.
Yeah. Okay. Ralph?
Well, I heard 4 big themes today, so I'll just summarize them very quickly. First is the whole concern about how to get paid for all these innovations. And I always cite this number, 1 in 25 and 50. 1% of the patients in America incur 20% of the cost, 5% incur 50% of the cost. If you don't reduce those costs, you're not going to reduce healthcare. And very few of the things I heard today are going to reduce that in any way. Secondly, there's a big effort to kind of really reduce transaction costs, which I think is incredibly helpful. So whether it's based on Uber or Airbnb, really get rid of the slack capacity in the healthcare system by reducing those transaction costs. I think that was a very fascinating part of what I heard today. Third, implicit in almost all the conversations were that these innovations are going to substitute for other more expensive innovations. There's no evidence of that over the last 40, 50 years. Almost everything has been additive. And there's much more quality in healthcare than there was 30, 40 years ago. But, you know, ambulatory care did not reduce hospitalizations. They reduced certain kinds of hospitalizations. For example, when I first came in the field, when people had chemotherapy, they were hospitalized for 14 days. Now they come into the outpatient setting for 4 or 5 hours. But there's all kinds of interventions. You know, we do open hearts on 90-year-olds now and hips on 85-year-olds. So hospitals are still here to stay because people like those kind of interventions. So I think most of the innovation here is additive rather than substitute. So it's interesting to me people kind of talk about these things as substitutes. They're not substitutes. They're additive to what's going on. And the fourth thing I just mentioned is when I listen to all these apps, and we do a lot of investments in this ourselves at Penn Medicine, I refer to this, I was once trained as a social scientist, and we always learned that in Indonesia, there's 1,000 valleys in Indonesia, and they all speak a different language. And all these apps are like a bunch of Indonesian valleys, where they're speaking 1,000 different languages. I'm very concerned about the fact that as much as we all say we should standardize, the effort's going in a different direction. We're not standardizing, we're going the wrong direction.
I'm not sure I can pull one out of that one.
Yeah.
I guess I'll say it's a big challenge. Okay.
Well, it's fascinating. I love these apps. I love them myself. But you know, when you think, I've lost track of how many iPhone apps there are in healthcare. 50,000. Somebody in the room knows that number. But on how you keep track of these kind of things, and they keep proliferating, and exactly how you get kind of consistency in healthcare.
So one thing we know is people are going to be looking for healthcare tomorrow,
yes.
Whether they're because they're worried and they want to be told they're well, or because they're sick.
Mm-hmm.
And we know that they're going to get cared for
yeah.
at some level. You know, we're seeing, as you begin to weave together, you know, Bob's cost issues and Emily's retail issues and the new technologies that both of you guys have referenced, we're seeing more competition. Okay, and it could be across the street. It could be you know, the doctors that used to be on your staff becoming your competitor. It could be the health system across the street. It could be telemedicine. You know, medical tourism. It could be any place in the world. Okay, how do we sort of deal with your issue of you know the Tower of Babel? That's what I like to call these dialects which don't talk to each other. How do we deal in this increasingly competitive environment where cost is a very big issue, where there's going to be an empowered consumer? Okay, I mean, what happens? Do we move to Brian and I'll start with you, Brian. Do we move to less collaboration? Do we move towards an even more complicated ecosystem? And then when you start to look for your barometers and you start looking for adequate sample sizes to judge whether or not something works or not, or you're a referral center, quaternary care center, you're getting patients from every place, and you want to know the history, how does this all work? So very open-ended question, but what's the role of competition going forward versus collaboration? Brian.
It's interesting, David. I wonder, from an industry structure perspective, if over time it's actually not going to get more simplified versus more complicated. We did an analysis recently, and when thinking about changes in industry structure, funny things can happen, strange things can happen. So we find it instructive to follow the money. So we did an analysis of aggregate earnings in the life sciences and healthcare industry. In 2013, there was about $250 billion in earnings. And if we plotted it on an X and Y axis, and you could see the distribution by the subsectors within the industry, and interestingly, providers accounted for 36% of the earnings, the most of any individual subsector, yet they're the most fragmented. So with this movement towards value-based care, the clinical and financial risk is more and more going to be residing with providers. And I think providers their role is going to be elevated in terms of looking across the ecosystem and asking the question, whether you're a med device company, whether you're a health plan, whether you're a pharma company, a distributor, what is your value proposition to me as a provider who's taking on the clinical and financial risk of an attributable population? And if you don't demonstrate a value proposition to me, then your role in this industry is going to be diminished. And so I think it's, given there's an enormous amount of uncertainty, I think there's questions around what are plausible scenarios and how could they unfold. I think one plausible scenario is that providers continue to consolidate, continue to increase their scale and their influence in the industry, and make it, frankly, a lot harder for other industry constituents to get by on the margin with some new innovation that doesn't ultimately solve their problem around better managing clinical and financial risk.
But I don't see the competition. I mean, you said earlier, and Ralph said the same thing, all healthcare is local. But your strategy as a hospital is to get as much market share as you possibly can at the local level so you can leverage when you're negotiating with the insurance company, and they're trying to do the same thing. Humana put themselves on the market today. So where's the competition? I hear this all the time, what's going to happen? And my own strong view is that Congress needs to do what it started to do in '96 with HIPAA, which is to get everybody an identification number so that, I've been to 30-some doctors. I'm 71 years old, and when I go in to see a physician, he has no idea what the hell happened to me in 1960. And in addition, I think Congress needs to mandate that hospitals provide their prices, and the insurance companies tell us what they're paying. Then I can make a choice. Then maybe I'll get competition. I understand that it's not like going out and buying a car, but I get a colonoscopy every 5 years, and it's damn near like going out and buying a car. I'd like to know what the price is in Newark. If it was less than it is here, I might drive across the river to get a colonoscopy. But I don't know the price. And I don't know what the insurance companies are paying. And I do know that there's substantial variance in the one thing that we've all experienced, which is birth. 4 million live births every single year. I know you can at least give me that price because it's scheduled. Tell me what the price is for your normal vaginal delivery. And you're going to see tremendous differential across the country and not really be able to make a case. You're going to find out it's more expensive in low-cost areas, oftentimes it is in high-cost areas. But give us the numbers. And the only way you're going to get it's not going to happen voluntarily. Congress is going to have to mandate that we get an identification number, that we control that data, and Congress is going to have to mandate that both the providers and the payers tell us what their prices are and tell us what they're paying.
So, Ralph, what do you think? Does that have traction?
I think I was saying to Senator Kerry just before we walked in here, I'm a big fan of Obamacare, Affordable Care Act, but we did it the wrong way. Like I would have preferred we did Senator Kennedy's Medicare for All. So I think instead we made healthcare much more complex. And I understand why we had to do it, to get the votes to get it to the Congress. So I'm still in favor of it. But healthcare got much more complex the last 4 or 5 years rather than simplified. And we have in some parts of the country 10, 20, 30 different offerings between these new networks and exchanges. So it's just getting more difficult. So I think Senator Kerry's hope there for more simplicity, we went the wrong direction. I still think it was worth getting the act to get it, but we made life more difficult for consumers and patients.
So are you saying that there has not been an intensification of competition, that you're...
Well, as Avi said in the introduction, there's a lot of consolidation going on around the country.
But is that to gain leverage or against the insurance companies, or is that to
this is all John Kenneth Galbraith's countervailing powers. So the insurance companies got bigger. We had Anthem here earlier. Anthem is the Blue Cross in 14 states. They got bigger. The health systems get bigger. And so this is happening around the country. I've written about this. There's not much evidence of economies of scale in medicine. Quality doesn't get that much better, cost doesn't get that much better, but what gets better is market power. And so you basically have market power on the insurance company, market power on the providers, and that's why healthcare in part is so expensive.
So I'm going to pick on you a little longer, okay?
Yeah.
Okay. I promise to spread it around. Okay. So you run arguably one of the top 5, top 10 academic medical centers in the country. It's your record is enviable. I suspect that many other CEOs and deans would love to have the resources and the talent that you've amassed. Are you worried about somebody coming into existence and grabbing the colonoscopies, which you're charging more than the community hospital across the street? Are you worried about your women's and children's care, normal deliveries, not high risk, but are you worried about having erosion there, some of those are margin creating. And
yeah. Well, I'm not. I mean, we're a good local brand name in the 100 miles, so I'm frankly not that worried about people coming in. I would also argue that we spend a lot of attention to getting it right the first time. So what I do with my local Blue Cross, I argue, and we have the data to prove it, that we diagnose it right and we treat it right. We don't run the taxi meter, so we don't have the higher rates of utilization. We don't do spine operations and lower back pain. So we pay a lot of attention to getting it right. We think that our price per unit may be a little higher. We just do less interventions per 1,000 people than other people do. So I think that's a value proposition.
So you're not worried about being cut out of a network, not being in the top tier, or not being included in a limited network?
I agree with some of what's been said today. I think some things become commoditized, especially things that are, as the senator says, that you can predict in advance. So I think births will have more of a commodity rate, and I think elective hips and knees will have more of a commodity rate, and colonoscopies and MRIs. So you get the apps, and you'll get the apps just like you go price out Amazon and so forth, and you start pricing out. Look, you're in the middle of breast cancer, you're not going to start negotiating your MRI, but you want the same doctor as before. So I think the more intense procedures, it's much more difficult to get the kind of transparency that everybody wants. But certainly on the elective procedures, you will get transparency.
So the member of the panel that's closest to the consumer every day of the week is Emily.
Yeah.
I mean, you don't get third-party payment for what you provide. So
Correct.
What's your experience?
Yeah, I mean, I think that things are really shifting. In the past, so many decisions have been made at the level of the providers and the level of the payers, and consumers are getting frustrated and irritated, and they are getting engaged in their health. And so how do we empower them? People are interested in paying $99 to access their genetic information, and it'll be interesting to see for other health services if we had the level of transparency that you're talking about, and these kinds of apps like Castlight to sort of evaluate how much does a service cost. I think patients and consumers would be very interested in that. I mean, we're seeing it really strongly just with genetics, and that's a tiny piece of the whole healthcare puzzle.
So at the risk of maybe getting a dialogue between you and Senator Kerry started, tell me about literacy. Tell me about, whether people, how that segments the market. And
this is interesting. I can speak specifically to genetic testing. Yeah. When genetic testing first became available to individuals, there was a lot of concern about whether people could understand this information. A lot of physicians spoke out strongly against it, that people would not be able to understand it. They would make rash, impulsive decisions. They would have lasting distress and anxiety. And those are empirical questions. And people have now studied those outside of 23andMe for about a decade. And found that for the most part, if you present this information in the right way, people can understand it. People do find it useful, even if there isn't something directly actionable that they can do, like the case of Alzheimer's disease. There's no treatment, there's no disease-modifying therapy, but there's research that suggests that a large portion of the population actually find it beneficial to learn this information, and they can understand it and then take the appropriate next steps. So I think as a healthcare system, we have a tendency to really be paternalistic about the patient, and that we are in an era of engaged consumers. We have a lot of resources to be able to learn about our health.
So you concur with Bob that we can empower consumers and get them to, force Ralph to change his pricing strategy?
I don't know that consumers will be able to fully draft that change, and I think part of your point, Bob, Senator, was about having policy. Policy will need to be a part of that, but I do think consumers can start pushing the envelope, and having the key to that, I think, is transparency.
Yeah.
I agree. Look, maybe the consumers are all stupid, but let us make the decision. Just give me the numbers. And by the way, particularly with the dramatic changes in communication technologies and our capacity to analyze data, I think there's tremendous upside opportunity to actually get improvement in quality with reduction in cost. But it's very difficult to get it done if that data isn't available, and even in the absence of the data. But I see on a regular basis people, first of all, who are highly motivated young people that want to help people get healthier. I mean, the most moving thing about our healthcare system is the queue of men and women who want to go to medical school. In spite of geezer doctors who are complaining all the time about how horrible their lives are, you've got young men and women who want to go to medical school because they like the idea of saving lives, not the idea of all the stuff they got to go through to be a doctor. So there's a lot of young people who have started businesses out there trying to reduce type 2 diabetes, trying to get people to eat healthier, trying to change the habits that we acquired at a very early age. So there's a lot of activity going on there. I'm not anywhere near skeptical about the future. I just would like to see Congress, and because we did it in '96. That's what HIPAA was. HIPAA was supposed to be something that gave us power and control over our own data. And 2 years later, we came back and defunded it. out of privacy concerns. So Congress, this is one where Congress could change the landscape in a hurry. Give me control of my data, because the hospitals and the payers are not going to do this voluntarily. They're not going to be transparent as a consequence of their love and concern for the consumers. It's only going to occur when you level the playing field and require that data to be published.
Well, I can tell you what your question is, but I'm going to ask Brian first. Again, ask about the role of government in helping to get good information out there. Okay, so you can think about it. Okay, you have many clients across the country that are engaging in value-based purchasing or are the recipients of value-based purchasing. Okay, and you're setting strategy for the largest consultancy in healthcare in the country. Okay, and you're trying to help guys like this, or the guys that are trying to compete with guys like this. Okay, is he right? Okay, I mean, is it going to be you can get away with the pricing strategy and sort of price commodity prices at low and mark up monopoly services high, or is this a short-run strategy and is somebody going to take them apart?
Well, I think one of the things that for all of us who've been in healthcare a long time know is that all healthcare is local. So we do not see across the MSAs in this country a standard peanut butter cookie cutter approach to to every city and market in the U.S. And that's because in each MSA the industry structure varies. I do think that Ralph's commentary around market power is incredibly important. I think there's a lot of strategic questions around how quickly to move from volume to value. So there are a lot of providers who are making a lot of money off fee-for-service today. Things are pretty good. There's a lot of providers who have very bad memories from the managed care days of 80s and 90s when there was a lot of money lost. One of the things that we worry about for our clients is, given that the industry structure is changing, there truly is, in our belief, a first mover advantage for those who go about it the right way. And the direction through first mover advantage is getting market share through a combination of Medicare Advantage, for some markets Medicaid managed care, and through partnerships with payers, especially in markets that have very large employers where narrow network products and offerings, as well as narrow network offerings on exchanges, can drive a lot of share. And so if someone gets there first and they have a strong enough brand, they really can take a big step forward to help lock up a local market where historically, because of the size of the market, there's been a long-term equilibrium because there's been lots of health plans, there's been lots of providers, and the market was at a point of stability. So I don't think it's going to be standard across the country, but I think that we expect disruption given that this transformation from volume to value is imminent.
That's interesting. So we see at least some strategic initiatives. We have Senator Kerry and Emily that are convinced that consumers want to be empowered, want information. Okay, there's information, there's cost information, which we'll talk about in a minute. But on the other side of things, whatever you call the other side, quality, service, outcomes of care. Okay, you touch a very narrow piece of it. Okay, what's the state of the art?
Well, I think it's certainly changing. I agree with Emily that the sophistication of people in terms of medical care and medical problems is much higher now than it's ever been before, and it's growing, and it occurs. It's not occurring as people grow up. It occurs when they get sick. When they get sick, they become experts very quickly, and so I think that the government's role is to put the science out in front, and we have to be incredibly careful to make sure that it's an objective, non-biased display of the science. And so I think all the institutes at NIH do this, the clinicaltrials.gov at the government, which puts all the results of all the clinical trials out there. We have to kind of make those more user-friendly, I think, for people to get the information they need. But I think that's part of our role. I think the other part of our role, which we are now just kind of grappling with, is the issue of data access. So the government funds $31 billion of research every year. Where is all that data? And it's hard to find. You can't find it. We need to get a system where that data is accessible to lots of people. The thing that's holding us back is the Bayh-Dole law, which states that the data belongs to the investigator. So by legal grounds, we have very little leeway. We have some leeway, but very little leeway to actually get that data accessible. But I think that's the next challenge for NIH to do, is to get the data that the taxpayer is funding and make it available. I agree that, as it was said today, when people got the choice, do they want to share the data, 75% of the people said yes, and widely want to share. That's not happening. Maybe 1% is being widely shared. So the patients are not getting what they want. They want to share their data. We're not allowing them to do that. And I think the Precision Medicine Initiative is maybe the first step to get people to volunteer, to say, I'm tired of this, all the legal games people playing. I want my data to be useful.
So bring it back to sort of the topic of the day, digital health, and we're hearing that there's a paucity of data, that there's a data out there,
a lot of data, but you don't know where it is, and you can't understand it. You can't find it.
Okay. So think about three functions. Think about sort of creating data that talks to each other, sort of data acquisition, maybe data retrieval. Thinking about analytics, okay, creating business intelligence out of that, okay, and then think about acting on the data, sort of the literacy, competency types of questions. Okay, what's the role of government as you think about those three questions versus the role of the private sector? And as you talk about the role of government, okay, and I'll start with Senator Kerry. Okay, as you talk about the role of government here, think about what's doable within, you pick a horizon, with bipartisanship being what it is. Okay? Senator Kerry, please.
Beats me.
Well, that's a good answer, though.
Well,
I mean, you're an expert.
The Bayh-Dole is 30 years old. That's Birch Bayh and Bob Dole. That's 30 years ago. So this issue of privacy is an exceptionally contentious issue. But there's a counterintuitive answer. You think you're going to get more privacy if you build a firewall around yourself, but you end up with less because the privacy is meaningless. I don't really. What can I do with it? I can't do anything with it because I don't know what the hell's going on out there in the rest of the world. So, I mean, one little pet issue, David, I'll sneak in here, was not related to the question, but I spent 16 years in politics, and I learned to answer something other than that.
Learned to answer the question they want to answer as opposed to the one they're asked.
First of all, I'm, without any additional elaboration, because I won't be able to distract myself, I don't think all healthcare is local. I challenge that fundamentally. If I present symptoms in Holdridge, Nebraska, that require me to go to San Antonio, Texas, I'm going to San Antonio, Texas. Plus, there's lots of clinical data that determine what we do at the local level that we acquire at the national level. So I would challenge that presumption, and challenge the presumption that it's desirable. I would like to see, my dream would be, that medical schools train clinicians so they do a better job of referring down rather than referring up. So I go in to see my doctor, he takes my blood pressure, he draws my blood, and he says, you've got high blood pressure, you've got high cholesterol, I'm going to put you on Lipitor. Rather than saying, I'm going to refer you down to somebody who can help you with your diet. I'm going to refer you down to somebody who can help you with sleep. I'm going to refer you down to different guys. And we don't do that because we have a different definition of health in the clinician's eyes. And I would like to see the healthcare. I think you'd get a lot more traction. And one of the biggest problems we've got is way too many people getting sick that shouldn't be sick. $200 billion on type 2 diabetes is spent every single year. And I would say at least half of that is preventable. But it's not preventable with Lipitor. It's preventable by changing the habits that you have when it comes to eating, when it comes to exercise. And those habits are not easy to change. And they're not going to change if the clinician refers up.
Not at all. Ralph, data acquisition, data analytics, data use. What's the role of government?
Well, they can be helpful, as Dr. Barrett talked about this morning, in terms of setting standards. And I think ultimately they're going to have to be more aggressive in setting those as standards. The marketplace doesn't work very well here. And I was once trained as an economist to the kind of logic of collective action. People don't cooperate on these kind of things if they think somebody else is going to get a free ride off paying for it.
So what's the enforcement mechanism? Is there one? I mean, you've run places all over the place. But
yeah, well, I think we use data as a competitive advantage. I mean, so we make enormous investments. We, like in many places in the country, are big epic shops. So we have data coming in, every second of the day, and we put in the big data store. And our nurses and doctors can get information on a patient and compare them to all the diabetics and all the people with heart failure on a touch of a computer screen. And so we have a lot of comparative information that we think helps patients out in a very powerful way. So we also invest a lot in data scientists and bioinformatics. So we have all those people there on staff to help us. And everybody's talking today about too much data, not enough information. So we invest heavily in the people who can help interpret that. So we see it as a real advantage. I would also say, I think the HIEs have failed around the country. 80% are complete failures. And I think you need to have more standards and enforcement behind it. I think meaningful use was a very powerful incentive for people to get EHRs out there, but still, the cacophony of noise out there is still there, and I think we need to have, some government standards that cause us to.
So it sounds like you're favoring government on data acquisition
on
and
standard,
you're letting
not on acquisition, on standards. But data acquisition, the big places like us, and it's not just the academic places. It's in our business interest to have this information to provide better care. So we don't need to be incentivized. It helps us to provide better care, and that's a comparative advantage.
So on the interoperability standards,
yes,
that's where government needs to be, and it should be, pretty tight enforcement is what
No,
I'm
I think this happens in many parts of the economy. You need those standard settings, and the political process is the only way to get it.
Okay. Walter?
Well, I think that we are missing a great opportunity because the data is not interoperable. It can't be put together. I can just give an example. We had a contest. We put out brainwave activity and asked people to predict when seizures would occur from firing patterns in the brain. And previously, it was like a 51% accuracy rate. We put out a contest, and some 26-year-old in Australia who didn't know anything about EEG, but is a great machine learning person, got up to 87%. So I think if we had a way of putting data together and making it accessible, on a contest like that, we could go for it. And I think that the only way out of this, because as was said, it's a competitive advantage to the companies. I think the only way out of this mess is if the patients take ownership of the data, and then there's a portal for them to volunteer to put their data up. I think that bypasses.
So I'll go sort of Emily's position here.
Yeah.
Okay, so if providers, if University of Pennsylvania, wherever you were before, Stanford, is that
Mass General.
Where?
A place in Boston.
Oh, I'm sorry about that. I'm sorry about that. But it's, so if they had a good housekeeping seal of approval, an accreditation or something like that, and said, we produce good data and we share good data, that you, Emily, thinks that the consumers would favor that place. That becomes an additional basis of competition.
Yeah, I mean, I think that's been our position, is that the consumer owns their data. And to echo what Walter is saying, so we have 1 million people in our database. 80% of those people consent to donate their data to be part of our research efforts. So people want to contribute. And the key is making a system where all that data can come together. And so when I think about the role of government and the role of industry, there's certainly a role for both. And part of what I think the value that industry brings is this real focus on the consumer. So we have a whole entity that thinks about product design and using the right words and pictures. And when I was researching at the NIH, we didn't have those kinds of resources. So how do we bring together some of that?
So my prompters over here are telling me I'm supposed to go to the audience soon, but so I'm and I always do what I'm told. It's right. So, but I'm going to actually put one more question to the panel. And then, hopefully, we'll get some questions from the audience. So I didn't, ask for 5 votes, but I would guess that based on body language, everybody sort of thinks better standards are important, and having some either incentives or compliance mechanism, to get these standards used is important. Okay. Where does the leadership come from in the industry to move this forward? Because all these people out here that want to do work on analytics or work on use, okay? I mean, they're waiting for you guys. I mean, you're industry leaders, to get your act together. Where does that come from? I mean, how does it happen? And what's the horizon? What's the imperative? Okay, Brian.
So one of the challenges is that we're in this chicken or the egg kind of scenario right now, where it's the movement from volume to value is a big leap. And in order to get to value, and if you take it to its extreme, global cap, you need control and you need data. And you need to be able to implement programs to intervene. You need to engage with consumers in a way that they can manage their own health. So I think that the question really is to management teams across all facets of our industry, who has the courage to take the risk first? You know, and if you look at models that work today at Kaiser or Geisinger or Intermountain, et cetera, what do they have? They've got control of their data. They've got control over interventions, and they have access to the first premium dollar. So when they drive down utilization, they preserve their own margin, and that's the future. And that's the way that, you know, I think that's the vision for.
So you're saying we have to wait for the new ecosystem before we're going to find leadership? I think
it's going to need to go in a very pragmatic, you know, practical, risk-adjusted fashion. And I think that's part of the reason why we need the government to be a catalyst around some of these standards and incentives. Yeah. Because what I worry about is that if we just allow the market to take the leadership, it's going to take too long. It's going to take too long.
Others? Anybody else want to jump in on that?
Look, I don't think it's going to happen unless you have federal law mandating it. I just don't. And look, I don't know how much we spent building EMRs over the last decade.
$28 billion.
A lot. And it's certainly better than running paper, and probably made it easier to bill. But we haven't really seen the clinical benefits, and won't, in my view, until there's real interoperability. And that interoperability will not occur unless Congress mandates it, because you're going to have battles that are going on right now between the sort of the big dogs, the incumbents in this space.
So this is the next SGR fix.
There is language in
it's
the
cheaper.
I know, there is. Yeah.
It's cheaper. This doesn't cost anything.
Okay.
This is a federal requirement that's necessary.
Okay. Audience, what do you want to know? Well, you're second. Please take the mic.
So this question is directed at Brian, but anyone can pick up. Brian, you talked a bit about the first mover advantage when it comes to value-based payments, and then you touched upon very briefly some of the first movers that you've seen where there isn't necessarily a huge paradigm-shifting drive at a health system or at a provider group towards interoperability. What other first steps can organizations take to get there and in order to realize those first mover benefits? So risk share agreements, things like that.
Can you tell us where you're from, please?
Mount Sinai Health System.
Okay. Well, and of course is extremely relevant for you given what's going on with Disruptive in the state of New York, right? So that you have, you know, a grand experiment here in the Empire State. The first thing is, I'll go back to what I'd said before around, it really starts with the local market strategy. And I agree with the Senator's comments that we have more mobility and options on a national basis. But the majority of healthcare is delivered generally on a local basis. Certainly from an executive decision-making standpoint, looking at the local market is a really important place to start. I think that this is one of the things I've been talking about with our clients is a bit of a Goldilocks strategy. You know, not too slow, not too fast. Because we have some executives in different parts of the country who are ready to jump all in with risk. They don't have the data, they don't have the talent, they don't have the expertise, they don't have the pricing, the actuarial. It's not easy to manage risk. And it's dangerous if you don't know what you're doing. And so we've actually had to say, hang on, stop. You know, you need to slow down, hit the brakes. You need a measured, practical, pragmatic roadmap to get from here to there. At the same time, we have some clients who are either really enamored with fee-for-service because they're making money or it's just too difficult, or there's an enormous amount of change fatigue. So a lot of executive suites, it's, you know, this is you know, exhale from the last 5 years of change through reform. And we also tell them, you can't sit idle. You have to experiment. You have to take some, so whether that's a a pay-for-performance contract, whether that's entering into an innovative Medicare Advantage relationship, whether it's, there's different models to move along the continuum, but in our view, it's a very dangerous proposition to do nothing. Because every single major payer in this country, federal government, state government, employers, and consumers, we have 20 million high deductible enrollees, and we've got, half of those are with deductibles between $2,500 and $5,000. That's real money. That matters to and they're going to vote with their feet. So, that's the perspective we're sharing in the market.
Okay.
Thank you.
Young man.
Betty Wall from LPA Software Solutions. I just wondered if anyone could comment on your confidence either today or in the future to be able to anonymize the data or de-identify the data to take larger cohorts of patients to predict outcomes by doing that. I just wondered if you've done that or if you have thoughts on that.
We do it all the time right now. That's not a problem.
The big providers do it all the time. Yeah, and I do think you're going to see more and more of that data becoming available. And on the payment side as well, the payment data gives them pretty good analysis of what works and doesn't work.
I think I think a caveat to that is genetic data, which is inherently identifiable, and so that's a place where we have to be really cautious about what data is shared at what level. But there's absolutely utility, I think, in sharing some of that data for some of the research and outcomes that we're talking about.
And do you think that'll become much more widespread across the general population over time? Because I don't see that as widespread as maybe it could be.
Nobody's tried.
Yeah, we have to internalize the cost of it. So, I mean, we're a big place, so we can do it, and it helps us do clinical research. And you don't have to put everybody, as you heard this morning, into randomized controlled trials. So you can look at hundreds of thousands of patients in a de-identified way and look for trends over a period of time. So I think, again, whether it's the Kaisers of the world or places like us, or Optum, which is an offshoot of Mayo, and some of the places in Boston where he used to be, they're doing this all the time right now.
And the Precision Medicine Initiative is going to try and do that as well. I think the one thing that I ask the computer geeks, will we get to a point where the privacy will be really secure? And what they tell me is it's never going to be 100% secure. So I think, we're going to have to make a social decision. Even if it's a minor risk, there's always going to be some risk to doing this. Probably never going to get away from no risk.
And I think this is where there's a role for legislation, like specifically on the genetics piece. There is legislation that protects against genetic discrimination, but it doesn't protect for everything. And so I think as we start thinking about the value of this data sharing, I think certainly it's so critical. We're going to then need to legislate ways to protect people in the event that the data is somehow mishandled.
Where it gets difficult is there's a fair number of people actually don't want us to know who's doing the best job. Right? So back to this, it's all local. If I need my knee done, it's not all local. I'd like to know who's the best, who's getting the best results. And there's not everybody, not all incumbents want you to know that information.
Thank you.
Yes.
Hi, Yates Conwell, Director of the Office for Aging at the University of Rochester, and a geriatric psychiatrist. My question, maybe I'd go with Senator Kerry first on this, is about the role of non-medical human services and how to enter them more fluidly into the mix in these discussions. If we make the assumption, I think it's a fairly reasonable one, that social and contextual factors really are powerful drivers of health, both at the individual and the population level, and that we do have resources in the community, and for older adults, that's through the Older Americans Act and the Administration on Aging, the ACL, down through the area agencies on aging and out into the community. These extraordinary resources, admittedly wildly underfunded, that have a lot to contribute. The impulse, I think, because we're so siloed in health, is within that health silo to try to recreate somehow social services or links to address social and contextual determinants of health when so much of that exists in the community, but because of the way funds flow, remain isolated from each other. got any thoughts about how we bring that together, and is that something we ought to be trying to do?
Well, I mean, yeah, I mean, there's a lot of exciting things that you can do, especially, again, with what technology allows individuals to do. But it's going to be very difficult to do until we geezers face up to the fact that we're screwing everybody under the age of 30. If you take the total cost of Social Security, Medicare, and long-term care Medicaid, just take that number and divide it by the total number of private sector jobs, it's a little over $20,000 a year for every person in the workforce, right? All those kids that have college debt or can't afford to go to college, I mean, we got to face the fact that we may have to give up a little bit in order to do these sorts of things. And man, that's hard because we vote, and the 30-year-old doesn't vote. And we don't have to be told that Medicare is important. We don't have to be told that Social Security is important. And we keep saying, keep your hands off my Social Security and Medicare. I mean, that was the deal on Part B. I mean, the whole idea, the reason we ran into trouble on funding in Part B was the law said you had to increase the premium. And the Congress didn't want to increase the premium. Because if they did, and you think, my God, we're going to be foraging in the alley for food if you ask us to pay a little more or take a little bit less. I mean, the total spending on Social Security and Medicare is going to go up $75 billion this year. And you would think we're impoverished. So unless and until, and it's going to get worse as the baby boomers go fully out, unless and until we look at this thing and say, we got to stop it. Because we're robbing, in my view, we're robbing from the future to pay for the past. Until we have the honesty to face it in that fashion, it's going to be difficult to come up with discretionary money to do the kinds of things you're talking about.
Okay. You can do it. You heard this morning on the presentation on the hospital at home. So if you're both an insurance company and provider, then in fact you have an incentive to use less expensive interventions, community health workers going out there to keep people from being hospitalized and so forth. So if you're a Kaiser, Intermountain, Ford, Geisinger, and if you're kind of globally budgeted, you have an incentive to do that. As you heard from the doctor this morning, Dr. Leff, if in fact it empties your hospital, you're not incentivized. So some of this comes from payment reform. I understand what Senator Curry is saying. We're spending a lot of money on medicine inside this country, and we can differ as to what the right amount is. But certainly there are systems in the country right now where there are incentives to do more appropriate social. And I ran Medicaid many years ago in Massachusetts, and in a sense I was an insurer. So I sent social workers out to the Boston Common every day to keep people from going to the ER and put them into a homeless shelter for 1/30th the price per night. So I was incentivized to do that because it cost me a fortune to go to Mass General, and not me personally, but the Commonwealth of Massachusetts. So we've had those incentives out there for 50 years, and in many parts of the country they work. But in a fee-for-service system, they're not there as much, and that's why people try to move towards ACOs and all those kind of things.
We're down to about 4 minutes. We'll take this question, and then we'll let you guys each get 30 seconds right at the end. The question, then 30 seconds.
Sure, thank you. Mike Townsend here with Home Hero. I was curious, Brian, you mentioned that the mentality should be testing a bunch of these things to see what works, and I'm kind of surprised that there's not more of a mentality around learning from what other countries do and sort of thinking on a more macro level internationally. Is there any opportunities that we could look at sort of abroad and learn from rather than inventing solutions ourselves? And if those sort of initiatives don't exist, is there opportunity for them to exist? Are there researchers that we could be sending to other countries to learn from their healthcare problems and how they solve them?
Well, we could spend a lot of time on that question. If you look at Canada, the UK, Asian countries, there's a broad spectrum in terms of how they deliver care. In the provinces in Canada, it's very much like what a Kaiser experiences in terms of they get a number and they've got to manage that number, and however they manage that number really well, they get to retain the margin for the next year. When you look at what's going on in China and India, they get to start in many cases with a clean slate, given that they don't have all of the legacy infrastructure that we have in this country. So using digital and using technology in new and innovative ways are very different. So I think that this notion of getting to risk from a clinical and financial perspective at the point of care is really important, and that's what we're seeing in other countries. But we have this legacy infrastructure that we have to deal with with whatever strategy we take as a country.
The health system reflects the culture of the country. And that's why I don't think you learn that much from other countries. You know, I've written about this. You know, we like markets and competition and liberty, and they like fairness. So you know, those countries are. So I mean, I'm just saying that as a scientist, you know, we love markets, and so we get all the problems of markets, and other countries get the benefits of fairness and planning. But it's very hard to export those kind of. And you never can extrapolate from Denmark and Holland to the United States. It's just the tiny little things. So you have so much heterogeneity in this country, so much inequality. So you have a health system that reflects this country. And so you can't take an egalitarian Scandinavian country and extrapolate to the United States.
So 30 seconds each. Okay, we'll start with Bob.
Thank you.
Closing remark.
I hope you notice I have strong opinions on some of these things. I've enjoyed the conversation. Thank you very much.
Emily?
Yeah, this has been fascinating. I mean, I think for me, I guess in closing, I think there's two pieces I'm thinking a lot about. The empowered consumer, there's a real drive there. How do we feed it? How do we use that, leverage it to correct some of these problems? And then the second is urgency. The system is collapsing under a lot of these issues, and I feel like there's a real need to be making changes quickly.
Brian?
So as we think about the change over the next 5 to 10 years, I think one of the critical things that we need to do as leaders is we need to be more trusting. And we're in a structure that is very vertical, very siloed, that if we're going to fix these problems, we have to work on a horizontal integrated basis, which is going to require new business relationships. And you cannot get to successful business relationships without trust. And that's going to require communication and understanding and experimentation, some failure and learning from those failures and moving on. But I really think that that's one of the biggest hurdles that we're going to have over the next 5 to 10 years to fix this system.
Well,
So I strongly believe that there are technologies that can come into medicine and displace some of the things that are costly now, and that we haven't really tapped into that, both from the research side and also from the care side.
Ralph?
Two simple points. Rich countries spend a lot of money on healthcare, and we're a very rich country. Secondly, as Uwe Reinhardt of Princeton says, one man's waste is another man's income. I used to go to Congress, and when Senator Curry was there, and I had to get in line behind pharma, now I have to get in line behind all the device guys. And they're everywhere. And so they may complain about insurance companies or hospitals, and they're everywhere too. So I think we're still in a world in which economics, as I said earlier, makes an awful lot of difference in how the healthcare of this country is run. I love all the innovation that was being described today, but I think it fits into the kind of general culture of a country, market competition.